Mike Corrick. This time it was easy because Phil Miller's local, but he is still a celebrity, so we're kind of lucky to get him. Okay, here we go.
Before I introduce Phil, I want to talk about the program. Next month we're having David Cowan, who is one of the teachers in the QXCI program. We have about 3 or 4 or 5 people here with QXCI. In case you don't know that, you'll have to come next month to find out. And you can tell by the long title, Unlocking Wisdom of the Body via Electrophysiological Reactivity Using QXCI Biofeedback. And he had some more words in there that I had to cut out. In July, I'm trying to get David Brownstein from October to July, but I haven't heard yet. And Ray Pete is coming back after 10 years to talk about protecting and restoring the nervous system. People who don't know, Ray was at least 10 or 20 years ahead of his time on many of the things that he was talking to us about. People, including John Lee, got all of his information started based on Ray Pete's work. I was just reading this in that publication, I think, about polling said if you're 10 years ahead of your time, you get a Nobel Prize. If you're longer than that, they call you a quack. And I think that's what happened with Ray Pete. He was about 15 years ahead. Anyway, then Stanfield is coming in September to talk about, what's the title again, Stan? I put it on my chair.
Making sense of heart disease theories.
Making sense of heart disease theories. And David Brownstein in October, if he doesn't do July, will be talking about iodine, why you need it, why you can't live without it. The title of his book that has become a bestseller around here, and everybody's talking about it from Rowan to Whitaker. I think they're just getting on the bandwagon.
It was just a big article in Jonathan B. Wright's newsletter.
Whose newsletter? Oh, Jonathan. Yes, he just got on too.
And we're going to have some more books next month.
Okay. Now, born in San Francisco, Dr. Miller graduated in the Centennial class at UC Berkeley with a degree in biochemistry. Prior to graduating from UC San Diego, he produced a 30-minute film entitled Waiting, a prescient documentary about evolving trends in healthcare delivery. It happened to have Dean Adele as one of the actors in it, I guess. For 25 years, he was involved in emergency medicine and urgent care, punctuated by training in neurology at UC Davis Sacramento Medicine Center. It was here that he trained on the first generation of EMI CAT scanners. In '94, he met with Julian Whitaker and went on to work closely with him for 1 year at the Wellness Institute in Newport Beach. He founded the Los Gatos Longevity Institute, and he now provides structured, comprehensive, time-tested programs. He is currently a charter member of the American Academy for Anti-Aging Medicine and has passed the first ever board exams in '97 and '98, qualifying as a diplomat on the American Board on Anti-Aging Medicine. And he is co-author of the LEF Revolution, The New Science of Growing Older Without Aging. When is that book coming out, Phil?
Came out Tuesday.
Where is it here? Can it be bought now? Can it be bought now? Have you got books here?
I don't read books here.
Oh. Okay, and other projects include a new distinct topical longevity newsletter.
My publisher doesn't want me talking books.
I give you Phil Miller.
What bookstore would that have done? Go to my website. Should people hear me through this? I'm going to have to use the other mic. I'm not sure this is going to be working.
It works fine.
Put it on your lapel. Can you hear me yet? Not very well. Can you hear me? Yeah. Can you hear me through the mic?
Yeah.
Yeah, that's fine.
Thank you. One of the advantages that I have is that everybody pretty much knows me. I feel somewhat like a prodigal son that returns. Maybe a little bit more well-known because of the book that we just came out with. What I wanted to go through tonight, when Phil asked me to do this, we started out with the concept of coronary thrombosis and how that relates to heart attacks. So as I went through this, this is in essence going to be a talk on inflammation, which is one of the main tenets in the book. And in going through, I'm going to give you just a tiny bit of insight, and then we're going to kind of launch into the slides. I'm going to give you a little tiny insight. I've been having a lot of requests behind the scenes, probably more than any other talk that I can remember. And everybody's saying, make sure you talk about this and talk about that. I sort of feel like what's going on in Congress, where they're vetting. Are you going to say the right thing? Are you going to do the right thing? So what we're going to go through tonight is I'm going to start out with, in a sense, kind of a conventional approach to heart attacks, cardiology, and how we really make these diagnoses. What's the technology that's used in diagnosis? Because I think in some ways what we're going to do is, everybody here is going to hear this talk in a different way. The younger people here are going to hear it as if they're invincible and this is never going to hit them. And some of the older people who are 50, 55, 60, 65, whatever, either it's happened to them, or it's going to happen to them, or it's going to happen to a relative. One of the most complex patients that I have in terms of cardiology, probably has everything wrong with his heart, came to me about 7, 8 years ago with an ejection fraction of 25%. He's done everything right. Stuff happens. No matter how good you are, no matter what you're taking, stuff happens. That's why I want to take you through this in terms of how do you deal with a conventional medical system so that you can get an idea what's the totality of what's going on, what's out there, what's the totality of the diagnosis, so you can get a handle on, at a certain point, what do you want to do? What decision do you want to make? And then remember, in many instances, it's not your decision. Because there's a family, and there's a husband and a wife, and kids, and uncles, and a lot of people who know what you should be doing. And you're a little mashugana if you still just kind of want to do one thing. So it's never just one person. You think that it's just you in terms of, this is the way I want to do this. If this ever happens, this is what I'm going to do. Well, you may find out that your family thinks otherwise. And so what I'm trying to do tonight is I'm going to show you what's out there, how do you deal with it, and then we'll get to the stuff that's going to be really creative. So we start out.
Turn it off.
This is who we are. This is the website. This is how you can buy the book. Talk tonight. So we start out, the heart as a metaphor. Because of any organ that I can think of, or in the brain, spleen, liver, the heart probably has more symbolic significance than any other organ. So it's not just what I'm going to talk about tonight, which is cardiology and the science of how we look at the heart. But the heart really has all these other meanings to us in the past. Some of them positive, some of them negative, some of them lofty. This is the one that I like the best. This is why I'm where I'm at now. And you can see this throughout the ages. Just to put this in the right spirit. First drawings of the heart were actually during the medieval period when, in essence, this was forbidden. You're not allowed to do dissections during the medieval period for many reasons. So the fact that Leonardo and then Michelangelo did the dissections he did in the cover of Darkness of Night was pretty brave. So even though we look at Harvey as the first to really show that the heart was the organ delivering blood to the rest of the system, even back there with Da Vinci and with Michelangelo, they kind of had a sense of what the heart looked like. This is what the thoracic surgeon sees. This is looking in and seeing what the heart looks like in terms of the beat before they stop it. This is the anatomy of it. So you can see here, basically, and we're going to go through this pretty quickly again. that you see. Here's the bottom of the heart, here's the ventricle, here's the top of the heart, here's the aorta. This shows basically the flow of blood. So you can see here blood goes to the lungs, comes from the lungs, it's oxygenated, comes back into the left ventricle, and is squeezed out to the body. So again, blood comes back from the body, comes into the right atrial ventricle, goes into the lungs, it's oxygenated, comes back in the left ventricle. That's the main one, pumps to the body. Left ventricle is the main part of the heart. That's the pumping. Again, showing the same thing. This shows, in essence, in a sense, this is what your cardiologist is interested in. A little bit more, but give or take, this is what he's interested in. He's interested in the EKG, stress testing, pipes, angiography. And I'm going to show you why it's a limited view. And we're not going to get too much into it, but there's some economic reasons why this is the way it is. But this is pretty much, when you go to your cardiologist, that's what he's interested in. Now, he might be sort of interested in some of these other things, but they're really not high on the agenda. They're real high on the agenda for me, especially lipid monitoring, because I do so much work with this. 2D echocardiogram, we spend some time with that. But again, if you look at the totality of that, this is a much richer picture than what your traditional cardiologist is interested in. The cardiologist's picture is getting more narrow, although that's about to change. This gives you a much richer picture: electrical, vascular, the biochemistry, the structure, regional perfusion, and then finally where I think really it's going, energy metabolism. So if you look again at how this comes out, again, electrical, vascular, biochemistry, mechanical, it's the force and the beating of the heart, energy metabolism, and hormonal, and immunology. And in a sense, what we're going to do is we're going to finish up with the immunology, but there's a lot of interest in this area right here. So let's look at vascular, because this is where it all starts out. This is what coronary arteries are. This is the vascular system. So another truism, result is our arteries, which is one of the reasons why diabetes, to me, is so important, because diabetes is aging in fast forward. Diabetes is a vascular event waiting to happen. So diabetes is just this whole thing just being moved ahead real quickly. So here's the main structure of the heart. Here's the right side. Here's the left side. This is the main. This is the left anterior descending. Again, what the cardiologist doesn't see, what you see in dissection, this is the richness, the plexus of the heart. So it's not just those vessels that I just showed you. Look at how rich this is. This is not seen on coronary angiography. That's what's important in terms of flow around these vessels that's not being seen. So this is sort of what was the traditional concept of coronary artery disease, and that could be aortic disease as well. And this probably goes back maybe to say 20, 30, 40 years ago. And that is, in this drawing, what you'll see is that most of the stuff is in the lumen of the artery. So it's inside the lumen of the artery. I'm going to show you how that concept is changing, because here, this lends itself to the old notion, all you did is you ate too much butter, too much Haagen-Dazs, clogged up your arteries, you got heart disease. Pretty static approach. That's why we were supposed to take all that margarine, which even as a kid, I never bought into that. I always thought butter tasted better. So again, I want you to look right there. And then here's a cross section here, and again what you can see is, and we're going to go over this over and over again, so it's a bit repetitive in terms of, here's the lumen of the heart and the lumen of the vessel, here's the intima, which is the lining of the vessels, here's the media, this is the muscular layer here, this is what makes the artery contract or expand, and then you have the outside, which is the adventitious, part of the outside lining. But I think one of the things that is really critical is this thing that's called the basement membrane. And I'm going to show you how that becomes a critical point. Again, there's the basement membrane. So this is a normal artery on the left, and here's an abnormal artery on the right. Now we're beginning to show a little different picture, because now you can see all the stuff here is actually not on the inside, but rather in the intima right here. So this picture is already beginning to shift our notion of what is going on here with cardiovascular disease. And again, the same thing here. Now we're beginning to see, here's the vessel lumen. This is what the cardiologists are interested in. You got narrowing, set up for angioplasty. Because what's going on right here is you've got this thickening of this plaque right here in the intima. Okay? So what we've done for the last 25 years, and I've done this talk in front of this audience a year or two ago, is we spent a lot of time going over complex lipids. And I'm going to go over this real quickly because it really, I spent a lot of time with this. It still remains important, but I'm going to show you how this fits in the grand scheme of things. We started out with cholesterol 30 years ago. Cholesterol was it. To me now, total cholesterol means very little. You could have a woman come in with total cholesterol of 240. I'm not worried. You could have a cholesterol of 160. Might be dangerous. Why? Because it's the breakdown of the LDL, the HDL. And now we've got to break down the HDL into HDL2, HDL3. We've got the VLDL. We've got all the ratios. And we've got now the advent of VAP and Berkeley Heart Lab testing, which are much more sophisticated pictures of how all this fits together. In the end, it comes down to, well, let me go ahead. These are our modern, this is what I do a lot of. This goes beyond what virtually everybody else is doing, which is the more forward-thinking and probably more predictive parameters, which is fibrinogen. And I like to think of this more and more now. Fibrinogen, I used to say, was kind of like how thick your blood is. It's like 10 weight blood, 20 weight blood, 40 weight blood. It's what thickens your blood because it's filled up with all these little particles of fibrin. The fibrinogen leads to fibrin. But really, fibrinogen, I'm seeing more and more, is an acute phase reactant. It is a way of looking at inflammation. So people who have fibrinogens that are low, I'm okay. If they're medium, okay. But if they're really high, I'm really concerned about these people. What you've been hearing a lot about is CRP, which is C-reactive protein. C-reactive protein, again, acute phase reactant, a way of looking at inflammation, a way of looking at what's the internal milieu, how inflamed are we. So fibrinogen and CRP, I think the fibrinogen is actually a more sensitive measure. You're not hearing about it. What you're beginning to hear is a lot about this, but you're going to begin to hear about this more. Lipoprotein A is probably one of the most important of all the lipids because it's even more important than LDL. Your doc, I'm going to show you why he's focused on one thing, but in fact, we should be focused on this. The problem with lipoprotein A is there is no drug for lipoprotein A, except for niacin, and I'm going to show you some other ways of treating this. But there is no standard way of treating lipoprotein A. So it's sort of just brushed aside as, oh, don't worry about it, when in fact, I think this is a major, major problem, one of the major risks. And then homocysteine, you know the story about homocysteine, how this started out 25 years ago and was initially considered to be a crackpot hypothesis. This has now gained widespread acceptance. This is an irritant. It is our ability, our inability of the body as we get older to take a normal amino acid and it accumulates. So methionine, instead of growing homocysteine and methionine, it accumulates in homocysteine. It builds up and it is irritating. So it is another cause of cardiovascular disease. These four things are a lot more forward-thinking. It's hard to get these done unless you ask for these. These are what these big particles look like, LDL and HDL. Now, I figured this out on my own, and you may even remember I told you this a couple of years ago. When I was in medical school, clearly the cholesterol theory held sway. High cholesterol, heart attacks. And even then, I thought, you know, I was eating a lot of ice cream and pizzas and milk and cheese, and yeah, it wasn't great, but I always had a cholesterol like 120. And I said, you know, there's something wrong with this cholesterol theory. I don't believe it. And all of my medical student friends said, you're an idiot. Everybody believes the cholesterol theory. I mean, of course, it's a given. I said, no, there's big problems with it. So what happened was we had the big Framingham study, which was one of the largest long-term longitudinal studies out of Framingham, Massachusetts. And interestingly, here you've got this curve right here, and it shows cholesterol, and it shows you here's those that had a myocardial infarct, a heart attack, and here who had no heart attack. And you can see they're the same curve. So therefore, cholesterol does not predict heart attacks. All the stuff we're doing that I spent a lot of time on, cholesterol is not a predictor. So theorem number one, and I've said this before and I keep saying it over and over again, association does not equal causation. And there's philosophical debates that have gone on for hundreds of years at the most cerebral levels regarding this notion. Association is not equal to causation. And that's been the problem.
There's not even association.
So we have pattern B. And pattern B is a low HDL high triglycerides. And what this is it's a new way of looking at LDL particles, which are either small and dense, and therefore atherogenic, or we have a pattern A, where we have a predominance of LDL particles that are large, buoyant, and less atherogenic. So you could have the same LDL number, but if you're a pattern A, better. If you're a pattern B, worse. These can be typed out. I'm going to show you how. So you look at these. Here's the LDL gradient, and this is how you have showing these different classes. So here's large and buoyant. That means this is going toward pattern A, and this is pattern B. And then you have the HDL. There's the HDL gradient. And these are now being subtyped out into type 2, type 3. And so you get this reduction, which again is more Cartesian in terms of reducing it more and more, trying to find the thing that is the answer. And in fact, I love it because I love the biochemistry just like Steve does, but it's not the whole answer. So here's the pattern B. And you can see this is the complexity of it. Again, I was semi-apologetic. These are the slides I hate. Like, oh, it's real complex. Well, I'm just going to show you basically. It starts out with the liver, and then you've got this mid-particle here. But this is really what the whole idea is, that you've got these small LDL particles, the pattern B, and the theory is that the small ones are more likely to get into the intima than the large, fluffy ones that are the pattern A. And so these are sort of the pattern A, and these are the pattern B. And that's the concept that, again, you can have the same LDL number, but different consequences because of that. This is, the Berkeley Heart Lab was the gold standard in the last 10 years. Mainly through the work of Robert Serpurko, who's really one of my mentors, and has a lab that's one of the best labs you can have, and goes into all this in exquisite detail, has the best CV, is the most accurate, but it's more expensive. And so what happened is, some very clever guys decided to automate this and call it the VAP. And nobody even in lab land knows what VAP stands for. It stands for Vertical Automated Processing. Now, basically what they did is they took Berkeley Heart Lab and they automated it. And so this is a $50 test. It gives you pretty much the same thing as the $300 Berkeley Heart Lab. So when the Berkeley Heart Lab is a gold standard, I'm running a lot more of these now. Because I'm giving you the same thing. So it's going to give you all these numbers here. And so because this is so cheap, this is something that outside of Kaiser, because Kaiser's Kaiserland, but outside of Kaiser, everybody can ask for this. You can ask your docs, could you run a VAP on me? And most of them will say, well, yeah, okay, or well, yeah. But you can get this done. I'm going to go through this real quick just to show you there are animal models that do show atherosclerosis. Here's the monkey model that shows atherosclerosis. So what we've come to, and this is the thing that I was really interested in, is what are some non-invasive ways of beginning to look at the effect of all this? The effect of the lipids I just went through, the effect of atherosclerosis, the effect of what's going on in the heart. So the calcium scoring came out about 10 years ago. And the one that was really first on the scene was the Imitron, which is now a supplement been taken over by GE. And that's called EBCT, which is electron beam. It's a different way, it's a super fast way of scanning the heart where they can gate it and they can slow the heart down and they get real accurate images of the heart. But it's only good for the heart. It's not really good as a general tool for the rest of the body. So it's pretty specific. Now when I started doing this 8 to 10 years ago, this was like, because it was like patient-directed, and it was like from the anti-aging community, this was looked on with a lot of scorn, like, yeah, it's kind of a hokey test. And I mean, of what value is it? We do angiograms. Now, this is kind of dumb. Well, this has changed. In fact, just to show you how it's changed, it's now in the Mayo Clinic. Mayo Clinic uses this routinely when you go to the ER to determine if you've got chest pain, whether you're staying in or not. You got a normal super fast CT scan, you're probably going home. But I just talked to a cardiologist a couple of days ago who is here in Palo Alto, real straight guy, smart guy, real straight guy. And even he said yes, and he kind of went on about the calcium scoring that I'd done on one of my patients, and accepted it as legitimate data. So this thing has attained a certain legitimacy. So the only thing that's going on right now is you got the newer thing called the spiral CT, and that's more generalized. So this is more accurate for the heart, but because this has more generalization, you get into the economics of who's going to have what machine at what place, what's going to be available to you. Basically, I use heart scan in, I think, Cupertino, because they have the best of this technology here. This is what the machine looks like. This is the GE. It's real fast. I've had it done. It takes like about 5 minutes. You're taking a deep breath and you're done. This is real easy. I wish I scored 0. I think I scored 15. One of my patients scored 3,000. I want to talk about him later on. So this is what you see, and even I'm not super good at this, because what you're doing is sectioning to the heart like this here. So these things here, calcifications in the heart, you don't want to see these things right here. So that's what they're looking for. And then on the camera, what they have is they have the ability of turning this into colors and really segmenting in terms of looking at different types of calcium, the density of the calcium. So you're getting a lot of information, non-invasive, scoring, giving you a good idea of what is your total calcium load, which is at the end process of this atherogenesis that we're talking about. So again, this is a score. This is on a pretty good guy. He had all these things down here. His total score was 3. Pretty low. This is a guy who came in with chest pain, was really worried, software guy. With a score of 3, he may have something, but it's a lot less of a problem here. Simple test. Okay? And what we did is we showed he had a little lesion here and a little lesion here, right heart, left main descending. This is where you don't want lesions. This is also not good. But with a score of 3.4, it's real low. Lower than mine. So the next thing we've seen, and we're seeing kind of this come online, and even for me this is difficult because there's different machines, there's different methodologies. It's like the $10,000 machine, the $100,000 machine, but they're all basically intimal medial thickness. So what you're doing here is you're looking at the carotid artery, and the assumption is that the carotid artery is pretty similar to what's going on in the coronary artery. The carotid artery in the neck, coronary arteries in the heart. So anything that's going on here is probably going on here. But an assumption. Not always true. Pretty good assumption. So the assumption is if you look at this here, here's normal, and then you begin to see this. So what they're looking at is they're looking at the thickness here and here. Okay? But it's pretty complex. It's not homogeneous. So the only problem I have is the thickness may increase, but you don't know what the quality of it is. And that's where the color Dopplers are coming in to show you the quality of what this is. So they're looking at it like here. This is how they're coming across with Doppler scans, and they're showing these images right here, and they can really look at different layers right there. So here's the carotid artery, here's the probe. Again, the really good ones are the color, intimal, medial thickness, IMT, who gives you a lot more information. Just another piece of the puzzle, non-invasive. And this again just shows you how both with men and women, the thickness correlates with future events. So they're trying to show you, but again, that's correlation, association. Is that what in fact really happens? This is the cardiologist. This is the cardiologist's home. Because what he's looking for is he's looking for these lesions here and how bad this is in the heart here. Now it's kind of interesting. I pulled this off at a legal site. And interestingly, it had all this stuff on here. Don't copy this, don't copy this. And their diagrams are all wrong too. Because remember, you see this stuff here? See how this is all just caked on here? You see no intimal thickness? These diagrams are all wrong. And they said, don't copy this. Well, that's fine, but they're all wrong. But it shows you the differences, and that's what the cardiologist is looking for, is different stenosis. So here's a 30% block, here's a 100% block, here's big trouble, here's a 99% block. But what I want to show you as we go along here, okay, this is where we get into Star Wars stuff. Let's see if we can get this to work right. This is fantastic voyage. No sound. It's supposed to have sound on it. Yeah, we have no sound. So what it's doing is,
inside a healthy
there we
heart,
go.
red blood cells and other substances can flow freely to the heart. The walls of the artery are smooth and uniform in thickness. Over time, however, fatty deposits called plaque can build up within the artery walls.
Now watch these particles here.
Plaque may
Now watch
harden
this
and
right
cause the
here.
artery to become narrow, a process called atherosclerosis. When atherosclerosis occurs in the coronary arteries, the condition is called coronary artery disease, or CAD. Untreated, coronary artery disease usually worsens and can lead to myocardial infarction, the medical term for heart attack. A heart attack occurs when a blockage in a coronary artery deprives the heart of blood. Most heart attacks are caused by blood clots that form in an area of unstable plaque. Plaque is considered unstable if its calcified cap is thin and vulnerable to rupture. A rupture exposes the fatty cord to the bloodstream. The exposed cord triggers the blood to coagulate or clump together, similar to the way blood clots at the site of a wound to stem bleeding. Inside an artery, a blood clot, called a thrombus, can block blood flow to the heart. Deprived of oxygen, heart tissue fed by the blocked artery will quickly die. The extent of damage sustained by the heart depends on the severity of the attack, speed of medical treatment, and the location of the blockage.
So that's the traditional cardiologist view of the heart. That's what they're looking for. And this is a picture, this is actually what you call a cine-angiogram. This is again showing a major blockage in the heart. Traditional picture is, you're looking for bypass here. This over here, this here, you're looking probably at angioplasty, you're looking at bypass. Again, static pipes, plumbing view. So, one of the interesting things in this journey about doing this book and coming out with this book is that it's funny how you sort of come to grips with people who, when you were earlier in life, you were your professors in medical school, and just with your parents, who were real dumb when you were kids. Suddenly, they became a little smarter as you got a little older, and you began to realize maybe they knew a little bit more than you thought. And so, it's interesting that I'm coming to realize that Brownwald, who was my professor of medicine when I was a medical student, was extremely arrogant, but also a brilliant man, probably one of the icons in American cardiology. But we just knew him as this arrogant guy who was our chief of cardiology. Well, it's interesting that in retrospect, I'm able to appreciate all of what he contributed, because here Brownwald said, this is one of the icons in cardiology in the United States. This guy started at UC San Diego, went on to have the most prestigious chair at Harvard. So you don't get any straighter than this. But in 1977, he wrote, an increasing number of patients are being operated on, not because of the presence of intractable angina, but because of the hope largely without objective supporting evidence that bypass will support life. In other words, what he was saying is, even in 1977, with this was just beginning to kind of gain steam and to gain momentum, and also, I think if you read the little thing, it turned out Nina Brownwald, who was his wife, was chief of thoracic surgery, so there were things that were going on at home, I think, that were being played out in the press here, where Brownwald's saying, I'm not convinced that all the surgery is warranted. We haven't given this full medical therapy. And in fact, harking back to 1958, the great speech of Eisenhower, it said, beware of the great military-industrial complex. He's almost saying the same thing here. He's saying, watch out about the complex. And in fact, that's where we have come to, is it has developed a $10, $50 billion industry. So, if you look at one other, again, here's circulation. Plaques occupy space, and this is what I'm showing you, implying the angiogram shows luminal narrowing, but the angiogram may be a poor tool to assess atherosclerosis in living subjects. And I'm going to show you why. It has to do with plaque stability. So again, if we move further, I'm going to come back to this point, because I'm going to keep coming back to each one of these points. This is what's my favorite. I like the echocardiogram. Again, non-invasive. It's a mechanical thing. It shows me like the cylinder of a car. It shows me the efficiency of the heart, the beating of the heart, the strength of the heart. Basically, it's a real quick way of looking at how strong is this heart. I'm not looking at pipes here. I'm looking at mechanical thing. Here's the 2D echo. Again, here's the top of the heart, the bottom of the heart. And so it's showing you here, and you know, this is where even I get lost. I look at echoes and fine, just show me the written report. What I'm looking for is this one number. They will give you all these other numbers, the size of the left ventricle, the intraventricular distance, the size of the atrium, the size of the ventricle, the end-diastolic volume. They'll show you a lot of numbers, and I've seen the variance from all the way from poor studies to really exceptional studies. But the one thing I'm looking for is I'm looking for the ejection fraction. That is the percentage of blood that's squeezed out with each contraction. So if your heart is failing, forget the pipes, forget everything else. If your heart's failing and you've got 25%, you're in trouble. If you've got 50%, you're kind of putzing along. If you've got 65 or 75%, you're supercharged. Kind of think about the old Norton 750 single-stroke motorcycle, big like that, where each stroke you're getting a huge amount of volume. 75%, you're home free. 25%, you got problems. So that's where these numbers come from. The acceptable is 50. I'm looking for 65. But I simplify these things. I look at all these numbers. Cardiologists, they look at all these things. I say, just give me the ejection fraction for this particular test. Then we go to metabolic screening. So basically renal flow. How well is your heart metabolizing? How well is it working? And what I like is what they call dual isotope scans. This is not exactly a dual isotope scan. This is called a SPECT scan. But you kind of get an image like this. One's abnormal, one's normal. And what it's showing you is you can have a normal angiogram, and you can have a really abnormal SPECT scan or vice versa. The more information you get, I think, the better. But this thing will actually show you a lot more things than the angiogram won't show you. And again, I like these. So this is the topic tonight. This is kind of an overview. This is what you're dealing with in terms of what can be done, what maybe is done, what isn't being done. So where does this all start? It starts with inflammation. And when I've gone through the literature, it almost looks like, in going through the literature, that some of these notions actually were being talked about really actually by Virchow in 1820, and then maybe in the late 1980s, 1990s. But you haven't really heard about this in the medical community, and certainly in the lay community, really until recently, just the last 2 or 3 years, when even Newsweek's talking about the inflamed heart, the inflamed person. So what this is all about is inflammation and how that causes a fibroproliferative response, and how it leads to growth factors, cytokines, and vasoregulatory molecules. So you have a conjunction of these factors here. This cap, remember they said the cap, that cap that really lines this atherogenic molecule, the atherogenic complex. This is what's sort of keeping it in place. You have large lipid core, you have small molecular weight. So what you have is you have a combination of factors here that are showing the dynamics of the plaque. And this is the lumen of the plaque. Here's that lipid core. So you see here's the lipid here, it's sort of rich and dense. And it looks like, from this picture here, that it's just lipid, just fatty stuff. But in fact, what I'm going to show you is that there's a real rich array of molecules and inflammatory things that are going on in this thing. So it's, again, not a passive just fat collecting, eating too many Big Macs, but in fact, there is this inflammatory core, so that you have this progression from a normal lumen, and a little bit here, and a little bit more here, and a little bit more, and eventually it leads to ischemic heart disease, cerebral vascular disease, and peripheral vascular disease. And actually, what's more important to the people that I see in my practice, I kind of figure that I can get you by the heart attack. Or a lot of people come to me, probably have sort of gone by that window where they're going to have the big one, like Mickey Mantle, waiting for the big one, never had it. I'm actually, and every one of you, in the end, ultimately, you're way more worried about this one than you're worried about this. Because that's the one that makes you senile. That's the one where you start losing cognitive power. That's the one that allows you not to get everything that's going on. That's the one we're trying to prevent. That's where you lose independence. So in the end, I'm actually looking at this, and so when I look at these risk parameters, I'm looking at, I want to prevent a heart attack, I want to do everything I can to keep you out of the hospital, keep you out of the cardiology suite, keep you out of the cardiologist's office. But long term, which is a harder take, long term, I'm much more interested in this than I am in this. Because that's what's going to keep you really fit and physical, like Don playing tennis at 74 with his little graphs. This is, again, what it starts out like. You have this progression here where you have a little bit of the thrombosis here or deep thrombosis. I'm going to show you there's some problems with this because, again, what you've got is you've got this core, and you've got all these things, and I'm going to show you how rich this gets. And what happens, you have a reaction, and eventually this, remember that cap breaks open because of all the inflammation, and it releases all that. It starts a blood clot, and the blood clot comes out here, as you saw, and that's what occludes the lumen. The question, when I've done the research on this, and when you really look into this, is how much of this is really just a reaction causing a thrombus, and how much of that is actually what you're not seeing very much, which is actually these little teeny feeder vessels inside here, vasa vasorum, little capillary feeder vessels inside the artery that actually may develop bleeding inside here that ruptures. And it's even hard for me to tell by doing all the reading how much of that is intrinsic bleeding in here versus how much is a reaction here that causes the thrombus, as you saw in the other picture. So then you get this real complex picture here. Okay, so what this means is this. Summary. You have the walls, you have the endothelium, you have smooth muscles. Endothelium, intima, the media. Inflammatory cells, the major ones are macrophages that are going around looking for bacteria, viruses, lymphocytes, and mast cells. Macrophages become foam cells. This is the really interesting concept. This is probably one of the take-home messages here, is to figure out what's going on here. What is going on here? This is called vascular adhesion molecule, and there's probably going to be more of these. There'll be a whole bunch more of these. But basically, these things here are on the vessel wall. Little things are happening there where there's sticky points. And those little sticky points, again, all that stuff that's going by, it doesn't just go into the vessel. It's being attracted to these little sticky points. This is one of the major ones. Vascular cell adhesion molecule. So again, what you see is right here, these are these little receptor sites or something, these molecules here, that then attract the LDL to come into here, gets modified, and it's taken up by the macrophage. This is the beginning of what they call a foam cell. This is the beginning of this reaction. So again, not passive, there's a real reaction going on here. Simplified, cartoon picture. So again, here's the left vessel wall. Here's that, they're calling it elastic lamina. That's the basement membrane. That's separating the intima from the media. It's real separated here. So everything's going on here, it's going on here, and they're all separate. Immediate inflammatory response, cytokines, risk factors, LDL, blood pressure, smoking. Smoking's the worst. Smoking really is the worst. At some point, this thing gets disrupted. And that's when all hell starts breaking loose, because these things start migrating in here, and you get more reactions going on. So you get these cells here, monos, B cells, T cells, lymphocytes, and you get more reaction here with macrophages, and then it gets even more complex with these cells here. And so you get more of this going on here, more migration here, inflammation. So what happens, you get this rich lipid core here, all these reactions that are going on, cytokines, inflammatory reaction going on. And eventually, again, either internally or something, this cap bursts, ruptures, you get the thrombus. Thrombus big enough, that's maybe in a vascular occlusion. Now it's limited by the fact that a lot of the studies that have been done in this are post-mortem. And probably a lot of young kids, you know, on the streets of Detroit, get sectioned and they got these things going on. A lot of older people get sectioned and they have none of this going on. So again, nice model, makes sense, but you always look at this because there may be some limitations with this model here. And in fact, makes a lot of sense here, but you know, is this reaction, is this actually what's going on? Is this in fact the answer? This is what's causing coronary thrombosis. Culmination of all these inflammatory events. So again, post-mortem, what you've got here is, this is the ruptured plaque right here, and you've got this. Now as I was doing this talk, I was starting to think that in a way, if you look at the inflammatory nature, pathogenesis of this, it's almost like this is what, you know, when I was doing emergency medicine and emergent care, it's like boils. It's like abscesses. It's almost like inside your arterial wall, you got this major inflammatory filled with all these white cells and foam cells, because that's what pus is, just a collection of a bunch of white cells. And so maybe you kind of look at this as just like this big purulent thing that's in there for one reason or another, and it bursts. The question before us is, this is the assumption here is that when it bursts, it causes the thrombosis. That caused the coronary event. Well, what I'm going to show you a little bit later is there a possibility that actually rupturing this, cleaning this out, and letting it allow out cleans it out? It's a question. It's a big question. Because some of the things that we can do more creatively, can we clean this stuff out? Okay? So, this starts here, again, a little bit of I made this sort of into an animated sequence. So this is a normal artery, and this is where now you got the cytokines, and you got a little bit more reaction. Now you got a lot more reaction with the foam cells in here, and eventually you got more inflammation, you see, and that's when it bursts. So the American Heart Association has typed these out into type 1, 2, 3, 4, 5, and 6. And this will all change. And it's the nomenclature of this, and the taxonomy of this is really difficult. Until I found this one series of slides by this one company here, where it made a lot more sense, because this is the sequence they're looking for. So there is a way that they're looking at this in terms of a progression. And again, so what we're looking at here is we're looking at the thickness here, and as the thickness grows, type 2, and then type 3, the thickness is growing further, more inflammatory events are going on, and the core is forming here, and then finally you get to 5, and you get to 6 where you get the rupture. Okay? So that's sort of the progression. Now in the last couple of years, the notions come about, well, maybe the initial event that would always been talked about, because in the cardiology text it's always said an initial injury occurs to the endothelium, which I've showed you here, And then it sets everything in action. And everything we've been doing in terms of cholesterol management and all the stuff I've talked about here is an afterthought. But what was the original injury? Vascular adhesion molecules, the load, the type of LDL particle. Well, one of the things that's come into the thinking is, we've had these talks in various ways, is this infectious? Are these particles, is it chlamydia? Is it cytomegalic virus? Nanovac? Any of a number of other organisms? Mycobacterium? Could be any of a number. Helicobacter? H. pylori? So there's a good possibility that this is an inflammatory, it's an infectious process. So it's only in the last couple of years that, and Tim will smile about this, is that I realized dentistry really is important. It really is more than just getting those fillings taken out, getting the mercury taken out. That every time you brush your teeth, you're showering your blood with bacteria. Because unless you're really, 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 really good and your gums are just pristine, there's bacteria, just all sorts of spirochetes and all sorts of fusiform bacteria that are in your mouth. Remember, as an emergency doc, the worst bite of them all is not a dog bite, the worst bite of them all is a human bite. We have more bacteria in our mouth than dogs and cats. So all that stuff has the potential of getting in that inflamed gum. Every time you brush your teeth, you're showering your blood. So you have an intact immune system that's taking care of it. But little bugs get there and probably are attacking our vascular system all the time. So maybe one of the things that's going on is that this is infectious. This is a whole new area that I think is going to blossom in the next few years. And so what's happened is just recently you've seen some studies they've done and they treated them with some antibiotics. The antibiotics didn't cure anything. They said, well, see, we've kind of showed that maybe it might be infectious, but that may be an unfruitful avenue. Well, I don't think so. I don't think any of that's been proven. You don't know what kind of antibiotics, you know what the dose is, you know what the timing is, you don't know whether they've been covered. Because I think what's going on, and what we haven't shown here, is the end point of atherosclerosis is a fibrosis, is the calcification. And I think the calcification is partly to wall off all this junk, but also walls off maybe the bacteria. And so when those antibiotics are floating by, you got this nice little calcium shell in there, and it's not being penetrated. It's like antibiotics don't get into the vitreous in your eye, it doesn't get into the bone marrow very well. So there's certain areas in your body the antibiotics don't penetrate well. And it may be this little calcified plaque, it's loaded with bacteria, it's protected. And what you need to do is clean it up, and then you hit it with the antibiotics. We don't know yet, but we're going to know pretty soon.
Have you ever cultured those lesions and
Let me get into that later. So here's the calcification. This is sort of the end point. And it's interesting, all the stuff that I showed you so far is that the calcium is not really part of this whole step 1, 2, 3, 4, 5, 6. It's all fibrin, which is fibrinogen, which then leads to the cap and so forth. But the calcium is really the end point. It's the ossification of this whole thing. So once you've got calcium, you pretty much got something going on. You've got a 0 calcium score, you're pretty good, but you're not home free. It's pretty good. And if you've got a calcium score that's real high, you got problems. Because at that point, you got calcium score that's 3,000, you got problems. And this is one that hemorrhages. So one of the things that, so maybe a new horizon for cardiology is, oh, well, maybe we can do is stick little transducers down there and we'll get a better idea. They're cool, but another way of getting into the cardiology suite, the angiography suite, sticking little ultrasound inducers in there, cool idea, but still you got this major thing in your artery. People get strokes, and people get angioplasties that they don't need, and they get bypasses they don't need. So these are some conclusions here, but one of the conclusions that I want to draw attention to, the reason why I've taken you through this fairly quick tour, is that for many years my goal has been, in terms of nutritional medicine, anti-aging medicine, all the nutrients, antioxidants, all the clever things we use, I'm going to show you this in a few minutes. My goal is, first and foremost, is to keep you out of the angiography suite. Really, my goal is to keep you out of the cardiologist's office. Because once I send you to the cardiologist, you've got a totally different universe than I do. And even the few, the 2 or 3 cardiologists I could even talk to at this point, in a civil, professional tone, we live in different universes. Because I'm going to show you what my routine is. It's not even worth me telling him what that is. Because it's just so foreign to them. It's over their head. It's just not in their universe. What is in their universe? Okay, so we're going to finish up with this, because there's some stuff here that remains to be known, which is, again, here's this fibrous cap, here's these CD cells, collagen, and collagen breakdown, and then it finally finishes up with this. And this is sort of a challenge to all of us, and the challenge to me is to figure this out. Because as much as I'd love to say I've really mastered hematology, I'm still grappling with this. But there's really some major stuff to be learned from this one thing here, because this is where fibrinogen, remember I said fibrinogen is the key? Fibrinogen turns to fibrin. Fibrin is the clot. That's what you're trying to prevent. Fibrinogen is the precursor. High levels of fibrinogen is a harbinger of this. Okay? And then you have platelets aggregating. So what can we do to prevent this thing here? And this thing here is TPA when you get in the emergency room. Is there any other way we can do that besides the emergency room? And what can we do in terms of platelet aggregation? So what can we do, this thing right here, to prevent the end point, which is the clot, fibrin and platelet aggregation? What can we do? That's the end point. I've shown you the progression, the pathogenesis of this, how we all look at it. But I think this kind of, to me, simplifies what I'm trying to figure out. What can we direct our therapies to? Okay. So what's the conventional answer? Statins. Put it in the drinking water.
Oh, God.
You gotta hate statins. I'd sort of been convinced for the last few years statins do work. And I have maybe 2 or 3 patients a year who are on statins, and they work. They are powerful. They do work. I think maybe, in 8 years, I've initiated statin therapy, I don't know, maybe once or twice. But you even look at the best cardiologists in the country who are doing nutritional medicine, Steven Sinatra, they'll be talking about statins. Because Steven Sinatra now is big. Deanie Dell, he's big. And the big thing is, when you get big, you get conservative. Because you got something to protect, you got a turf to protect. And so you sort of kind of pull back, well, statins are not so bad. Well, what do statins do? Let's look at this. Okay, so here's cholesterol. And again, I used to say facetiously, many, many years ago, before I really understood this, I said, cholesterol is the basis of all your sex hormones. And I thought, I don't want those diminished. Don't touch those. Let's not fool around with this. Let's figure out what we're doing here. So what happens is the statins, the HMG co-reductase inhibitors, work way up in the cycle. It's not way down here. It's way up. So they're way upstream. So, harkening back to those days when I actually tried to remember all this stuff, we were required to remember squalene and farnesyl, pyrophosphate, and then went to this and that. We remember the whole cascade of things. So we remember this mevalonate, farnesyl, squalene becomes cholesterol. So you had these long chains. You had these long chains here, and then eventually you go into the steroid ring. Okay. So further up, if you come right here, what's this going into? CoQ10. But look at what else is going on here. Vitamin A, vitamin E, vitamin K. It's a big one in my book. Don't mess with my vitamin K. And lipid-anchored proteins. And then further down, look at vitamin D. Anti-cancer, it's good for your bones. Oh, that's a pretty good one. Steroid hormones, don't mess with those. So you look at all these things here, here, and here, and here, you got some major problems. Now, but you get the levels up. Like you take Lipitor 10 milligrams, then you can take it up to 80 milligrams. Well, you got better, 25% of people will drop out of that study. What? Intractable muscle pain. Well, what do you think? They're losing all their energy. Intractable muscle pain. And a number of you here have suffered this, I'm sure. I'm sure a number have suffered this. I've had patients come to my office saying, they put me on statins. They're trying to kill me, doc. They were trying to kill me. I mean, really emphatic about it. I said, don't you ever put me on that. So we look at CoQ10. So what do I see in the paper 2 days ago? Statins shown to reduce breast cancer.
Right.
Who paid these guys? What is going on here? We need to put statins, we need to get little kids statins, Let them have their Big Macs, then you give them their statins, right? Just like my little nephew. So what's going on here is, I think what's happening is you've got these studies, and now we're beginning, the bloom is off the rose on this one. What I've been saying for years is, people would come to me, from the press, other people would come to me and they'd look at my desk, and if anybody's seen my desk is like Whitaker's desk, which has got all these nutrients on it. I mean, half my desk is all these nutrients. They say, do you take this? I said, yeah, about half of it. I take most of it. They said, well, how do we know this stuff is safe and FDA approved? And I used to say, well, I know all that stuff you're taking is safe and FDA approved. Okay? And the reality is, and now what we're finding out, is FDA approved means you did phase 1, 2, 3 trials, then you did some further trials, and then you put the medicine out there, and then you kind of waited for people to stop dropping dead to find out, was it really safe? So you had this Vox thing, FDA approved, boom, it's safe, right? Safer than all the NSAIDs, right? Less GI bleeds is a big deal. Vox makes a lot of sense, right? Well, what happens is, this stuff costs money. So to do these studies, it costs maybe $100 million at least to bring a drug to market over 8 to 10 years. And then you only have a patent for maybe about 6 years on it, because 10 of it's been wasted in bringing it to market. But you only do these studies for maybe 2 or 3 years, 5 years max. Well, a lot of this stuff, like CoQ10, I'm pretty convinced you may need to do this 5, 10, 20, 50, maybe up to 25 years to find out the long-term effect is deadly. It may take longer. I've seen these studies where you see things in 4 years, 5 years, and so there's curves that change, and you can't see it all in 5 years. Almost all studies are limited to 5 years, that's it, except for Framingham's study, which is longitudinal, it's been going on. This is a big deal. So again, it's really a big deal. This is sort of like, you've heard this, and we never know whether this is true. You've heard those stories like, well, the car companies really could make better cars, and they just buy out these patents, and they just keep the good cars off the road, because they want to make these really inefficient cars while you're driving these SUVs. And they just keep all the stuff. So this is kind of analogous. This is 1990. This is a patent that was filed. I actually took this off patent office file, showing that in 1990 there was a patent filed by Merck. Merck, look at this. To combine a HMG CoRate reductase, a statin, with CoQ10. You ever heard that one? Why'd they pull that one off? In other words, they've known this reduces CoQ10 forever. They've known this. This is no mystery. I wonder why all these people get all this muscle myopathies and terrible myopathies that can't, continue. This is really a mystery to us. It's not a mystery. This has been known for 15 years, at least. Carl Fokker says, turn over his grave. He knew this. So this was part of the patent here. The patent says an amount of CoQ10 effective to counteract the inhibitor-associated skeletal muscle myopathy. Interesting. What a mystery. What's being hidden here? So this is when I start getting really angry at these companies putting out these drugs and saying they're safe, it's FDA approved. No, they're not a problem. Well, there is a problem. It's more complex than this. It's really complex. What is safe is what is not safe. What does the FDA should be doing, which should not be doing? Remember, the FDA started because of the jungle by Upton Sinclair in 1905. And in 1905, he wrote The Jungle to show how bad the meatpacking industry was and why we should have socialism in this country. Everybody said, ew, that meat is a bad thing. That's how the FDA started. And it was also under Teddy Roosevelt, who may have been the last good Republican president we ever had. Or will. So what do I like? What do I want? So this is what you came for. What do I suggest? This is where I have problems with the cardiologist, because I believe this firmly, without any doubt whatsoever. Coumadin is rat poison. Coumadin destroys your bones. Coumadin is used for atrial fibrillation. It's used for valvular disease, but it makes the valvular disease worse. It hastens the valvular disease. So what's happening is Coumadin is being used to prevent the strokes. Good, I'll go with that. But it's hastening your aortic valvular disease. And it's interesting that my emphasis has shifted just in the last couple of years from everything we're talking about today, which is vascular disease, to valvular disease. Because that's what's going to hit all of you, is aortic valvular disease. I'm actually more worried about that than vascular disease. Almost. So, this is my routine. High-dose fish oils. And I mean high-dose fish oils, and you look at the EPA and you look at the DHA. I'm not interested in fish oil content. I don't care whether it's 3 grams or 5 grams or 10 grams. I'm interested in how much EPA and how much DHA you're getting. And I use extra DHA in addition to my EPA. And then the only debate that we can have here, the only debate is whether it's fish oils, which I prefer, or whether it's cod liver oil. I think they're both good. Our grandmothers, our great-grandmothers, all gave cod liver oil. They knew it 100 years ago. We really forgot that one. Turmeric. Turmeric is, reduces your fibrinogen levels, anti-inflammatory. Indians know about this. Vitamin E. Forget all the stuff you've been reading about, negative stuff about vitamin E. There's an agenda there. Just go to my website, read about it. This is an agenda. There's too much. Going back to Shute, going back to all the people who have been doing all the good research, for 40 years in vitamin E. This is an agenda. Vitamin E is good for you. You know that. Does it have some problems? Everything has some problems. Okay? You should stop vitamin E before your surgery because it works. So if vitamin E is so, it doesn't really do anything, I don't know, it doesn't really do much, then why is it the anesthesiologists know stop your vitamin E, your fish oil, before you have surgery? Because they know it affects your bleeding times. Okay? So vitamin E, ginkgo biloba. Now remember that model I showed you at the very end, fibrin and platelet aggregation. Ginkgo biloba works just the same way as aspirin. I think it's safer. I think aspirin is fraught with problems. I don't like aspirin. You'll even see a little aspirin in my book. I don't like aspirin. Aspirin to me are like NSAIDs. Aspirin leads to GI bleeds. If you use ginkgo biloba in the right dose, you got to be careful, the right dose, 60 to 120 milligrams. Because I've done 240, which is called the German standard, and I've had guys go to the emergency room with exsanguinating nosebleeds, and I thought, 240 is too high. It does work. This inhibits platelets from aggregating. So it's the same thing as all these other ones, Plavix, Persantin, Tyclet, all these other ones that they use, and all these expensive ones. And nattokinase is the one I'm really big on. And it works in different ways. I don't think anybody knows everything about nattokinase. The way I look at nattokinase is preventing fibrinogen from becoming fibrin. It's preventing that clotting. But I just learned recently that nattokinase is vitamin K in it. It does a lot of stuff. But I have seen more of my really bad cardiac patients do really well with nattokinase. This is the really miraculous stuff. In fact, it's so good, it's so strong. Personally, I don't think nattokinase should be over the counter. I think it should only be done on doctor supervision. Because I've used nattokinase aggressively on some people, And I've seen them have problems. One of my patients. I've seen them have problems temporarily where I think they had a little bit of a blockage, and then a week later said, God, I haven't felt this good in years. Went through a crisis and resolved. But I think if nattokinase works its job, it's doing, remember I said this thing is, should we maybe release all that stuff? Get through the fibrous cap, let that stuff get out? Well, if it gets out too quickly, fibrous, lesion. But maybe if it's done the right way, you can release it slowly, get rid of all this stuff. Nattokinase is great stuff. And nattokinase, it depends on the brand, because I only use one brand. And I think you can go down to Costco, you can get the cheap stuff, you can get the expensive stuff. It's not, you don't want to be fooling around with different brands. There's different brands. You want to know whatever it is you're using, you always use the same one. Just like thyroid. You don't want to be changing thyroid. You want to use the same thyroid. If you use Levoxyl, you stay with Levoxyl. If you use Levothyroid, you stay with Levothyroid. If you've been brainwashed and using Synthroid, you can change the Levoxyl. Okay, so what do the cardiologists use? Again, statins, okay? Anticoagulants, heparin, Coumadin, aspirin, Ticlib, Plavix, Persantin, all these expensive ones. Triumph of marketing. Triumph of marketing. God, these guys are smart. You're going to figure out all these things. What we're seeing now is right out because of what I've just shown you, everything I've shown you tonight. Oh, I see. What we're seeing is the statins are now being promoted as anti-inflammatory drugs, that they have properties that are pleomorphic. They do other things. Pleomorphic is like a man for all seasons. It's like what they're doing is, well, even when they don't reduce the LDL, we still see people getting better. And we see it really curing aortic disease. And we see it cure. Well, even if they have a high lipoprotein A, and we know statins don't do anything, we reduce the LDL and they're better. Okay? That doesn't make sense. But I heard, again, really good cardiologists tell me that. I said, well, yeah, I know that statins don't do much for lipoprotein A, but it lowers their LDL. Because they don't have anything else to do other than niacin. That's too pedestrian. Okay. Here's the new frontier. If there's anything in the pharmaceutical industry, because I'm not going to be 100%, I'll be 98% negative on our pharmaceutical industry. Remember when we first started medical school, they don't do this stuff anymore. Every guy who's over 50, when we started medical school, you get a little black bag. And they'd stuff it with a stethoscope and all this stuff. It was all from the drug companies. It's like, oh, really, this is cool, man. Day one, I'm a doctor, It's like, and there's Lilly's in there and Pfizer's in there. It's like, and that's how they started out, But how they really keep it going is, in the office, they keep sitting these really good-looking women. They're the detail ladies, okay? And even the guy said, no, I don't want to see detail. Well, maybe I'll see her. It's marketing. This may be one of the few that holds promise. So if you had a choice of all the stuff I talked about today, if you had a choice between a low LDL and a high HDL, you only get one choice. Do I have a high HDL, like most women have, or a low LDL? We're going to go for the high HDL. So I've seen women who have LDLs that maybe it's sort of high, but their HDLs are like 108. I've seen 123, which is astoundingly high. It's incredibly protected because HDL is the stuff that's going to the heart and sucking all that cholesterol and bringing it back to the liver and metabolizing it. It's the cleanup crew. It's the crew that's repairing everything. HDL is repairing everything. LDL is carrying cholesterol to the heart.
So what you want is that real tight ratio? Is that the idea?
You want a tight ratio, but I'm saying if you had a choice, this is going to be the blockbuster. I'm telling you, heard it here, because I'm telling you, you're going to hear this in about 3 or 4 years when this gets out of phase 2 and phase 3 trials. This is going to be a blockbuster. They're going to suddenly say, yes, statins are cool. Yeah, we got a drug that's even better. They're going to put the statin with this thing. That's what this is all about. So they really blew it by saying a Lipitor with this thing. Why not just this alone, whatever they're going to call it, okay? So again, they're still into, well, the statin will do two things. We'll lower the LDL, raise the HDL. This is where it's going. Saperco said this to me into an audience of us, 8 years ago. Said, we're going to see injections of HDL. That's where it's going. Women have higher HDLs than men. Men, as they get older, start getting HDLs that are like 40, 30, 20. I have guys with HDLs up to 8. Okay? That's terrible. I have women who have HDLs 68, 70, 123. I mean, it's astoundingly high. This is a real sex difference there. Niacin raises HDL. Okay, so what are the heart-friendly things that I use? Well, I talked about fish oils, CoQ10, carnitine. I'm really, really big on carnitine. I like carnitine tartrate. I like it in powder form. Hardly anybody takes enough carnitine. You cannot take enough carnitine. Well, you can, but you're not going to, unless you really, really work at it. This is my dose of carnitine, 3 to 6 grams. You're all worried about getting 1,000, 1,500. You want 3 to 6 grams. I take 3 to 6 grams every day. I stop. I start running down. This is what's feeding and protecting your mitochondria. Alpha-lipoic acid and CoQ10 and carnitine. This is feeding your mitochondria. Vitamin E for plasticity. I'm going to talk about this. This is the blockbuster. Taurine. Taurine is an anti-arrhythmic. Whitaker used to talk to us and said, taurine is really big in the retina and in the heart. And I've really seen that taurine is an anti-arrhythmic. So it regularizes the heart. Ribose is a new one. Steve Sinatra is really big on this. I've been trying it. I'm not too sure. I like the idea of it. This thing here is a substrate for ATP. I am really big on testosterone. Testosterone, the heart is a muscle. After 55, after 47 in women, after 55 in men, we are all losing testosterone. The heart is a muscle. You lose testosterone, you're losing mechanical advantage. You need testosterone for a strong heart. Failing heart. The problem is that the failing heart in traditional medicine has been treated as a temporizing measure. We're marking time. We're marking time between either now and when you leave, or between now and when you get the operation, or now and when something else happens. These things, what I'm trying to do here is to show you, which you all understand, but I want to reemphasize it, and eventually, a wider community, that we need to start looking at cardiology in terms of rejuvenating, resuscitating, and rehabilitating. And it can be done, just like it was considered heretical that you could reverse coronary artery disease 25 years ago. The notion that you could, once you got it, you got it. That's it. Game's over. Big studies have shown that's clearly possible. What we need to begin to do is look at the heart muscle as rehabilitatable. And so you need testosterone, you need estrogen, thiamine. Thiamine led to beriberi, which is heart disease. Vitamin K is really critical. I'm looking at that. I still don't know the exact dose. I still don't totally understand vitamin K, but it's going to be a blockbuster. It's just really important because vitamin K controls calcium flow from the tissues back to the bone. Vitamin K does all sorts of great stuff. It's really important. Heart-friendly niacin. So even in the traditional community, I don't believe in vitamin therapy. I said, really? What about vitamin B3? Well, that's nice. Well, what about folic acid? What about B12? What about B6? Well, I guess there are some. I wanted to do this thing, just a real good talk to just standard cardiology community. Says, I don't believe in vitamins. I said, really? Okay, so let's see. How do you treat Wernicke's disease? Well, that's thiamine. Okay, and how do you treat pernicious anemia? Well, it's B12. Well, how do you treat lipoprotein? Well, it's B3. So, all this stuff is really ensconced, even in conventional medicine. It's just, don't quite look at it that way. Well, we use those things. But these are some of the really powerful things here that are therapeutic agents. I'm using Folapro, which is 5-methyl tetrahydrofolate, because folic acid deficiency gets really complex. And it gets so complex that you've got different breaks. It's more than just what you've heard, which is the MTFHR break. It gets even more complex. I just read something in the literature that I was reviewing that some people actually have antibodies to their folic acid receptors. So, folic acid is when you look at homocysteine, my experience, most doctors say, oh, well, I treat homocysteine, it's really easy. No, it isn't. When I treat homocysteine, I'd say about half of the people I treat don't get better. The other half respond really well because there's so many areas where you can be blocked and you can get absorption and genetic blocks and so forth. It's not a slam dunk, but it's worth treating as much as you can. We know all these. It's worth repeating. Exercise. Even I don't get enough exercise. And, you know, I'm really, really lucky. I've got, my daughter is my assistant. And my granddaughter is at the office every day. And that's really, it's a big plus I never even counted on. It's one of the things, even when I get really mad, I'm really irritated and stuff, I just look at my granddaughter and it kind of dissipates a lot of stress. But I watch my granddaughter. My granddaughter does not walk. She runs all day long. All day long. So you want to know why kids have such high metabolism? They are running all day long. She doesn't walk anywhere. She is off the wall all day long. Running, 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 running. She gets so much exercise, and here we are with our clickers at night doing this, okay? High protein, low carbohydrate, low fat diet. I'm really big on this. I'm really big on whey protein. I have my own whey protein. Whey protein, as Stan mentioned, is an extremely complex subject. There's isolates, there's concentrates, there's different temperature, there's all different ways of doing this. I'm really big on whey protein, but it's got to be extremely high quality. I'm looking at rice protein. I don't think it has as much protein value as the whey base. No smoking. I mean, that's an obvious. But, you know, the 1 or 2 patients in my practice who do smoke, you can tell. I mean, they just got so many more problems. You know, nicotine hits the same receptors as heroin. Nicotine is the most addictive drug in our society. Forget heroin, forget speed, forget cocaine. Yeah, I mean, those are bad. But I mean, you know, widespread, the most addictive drug in our society is cigarette smoke. It's nicotine. Because you can't stop. It just gets you. So it's just such a destroyer of the vascular system. Remember I started this thing out, you're as old as your arteries. You smoke, fast forward. Alcohol. Now I'm really in the minority on this one because every one of you is going to have your different ideas about alcohol. And I've heard I just heard even Mehmet Oz, who's on the circuit, a really articulate guy, and I'm really happy that he gave me a very nice testimonial in the back of the book. So I'm really indebted to him. But he said guys can drink 2 drinks a night, maybe. But if your triglycerides are 300 or 400, no, you can't drink at all. So it depends on what your triglycerides are. It depends on what your alcohol tolerance is. I've seen some people who are alcoholics with 1 drink a night. I've seen others who are heavy drinkers with 4 drinks a night. Depends on what your personality, your enzymatic ability. But in general, I don't think alcohol is good for it. If you think that it's the red wine, satanas, all that, fine. Eat a lot of resveratrol. Just do it that way. You get a whole bunch of other antioxidants. I don't buy that theory. Okay. And the thing about the French, the French paradox and all that stuff, I think, and I've always thought, the main thing about the French is they don't pay out. You ever gone to a French restaurant? They give you this little teeny portion for $100. But it's arranged really nice, it's like, and you watch the French. We used to, when I was a lot younger, when I was traveling in Europe, you'd see all the frogs, and you'd see all them, and they were really thin, and they just going like this, and they're just eating like, like a grape, just a little thing, and we'd all be pigging out. That's the French paradox. You can say some others too. Some people say it's the south of France and the light in the south of France. This is really important. We know this is important. And Stan talked about this last time. We're all working on this, and it's getting worse. I'll just say, beer is being manufactured in this country. People are driving nuttier and nuttier every month, and people are out of control on the highways today. They are completely insane. You drive 17, the way I drive it, and you've got angry young white men. That's what they look like to me. They're all angry young white men, and they are looking for holes. It's like transistors. They're looking for holes. That's what they're doing. That's their whole thing. They're looking for those holes, and they're going 100 miles an hour. People are out of control. Stress reduction. I mean, these are some of the ones we know about. Meditation, breathe. I have to tell myself that over and over again. My friend Bobby knows this. Breathe. Just stop for a minute. Just breathe. Take it in, okay? When Dharma Singh Khalsa used to start the the A4M, when he started his talk, he would go, okay, now everybody up, and we'd all breathe, and we all felt stupid, but you did feel better, because you got up and you breathe, and he would talk to you about breathing, stimulating pituitary, and getting the brain moving, and sniffing exercise. Breathe. I mean, that's what meditation is all about. It sounds silly, but boy, I could learn a lot about that. We could all. I don't know if you remember David Zava when he gave his talk about 2 years ago, and I asked David, because I really like David, and I like the work that David's done. I think he's done some really good work on breast cancer, and I'm really big on DHEA, and I said to David, what's the best way of getting cortisol levels down? I'm thinking David would agree with me, like more DHEA. DHEA, cortisol, I look at that balance, that's your stress axis. And I remember, if you remember this, he said, love. I said, no, David, the biochemical part of it. Love. Okay. And then he started talking about his farm and his animals and so forth. Whatever it is, we need more of it. Because what we got is fear. That's what we got. And I'll tell you, fear causes heart attacks. Love, maybe. You maybe die of a broken heart. You're going to die of fear. We're way quicker. Yeah, Tim will really appreciate it, and I'm appreciating this more and more. Dental hygiene. I'm really big on. I think the biggest thing that's ever come out is the Sonicare. Get it? The Sonicare. It's the first time I've ever been able to really brush my teeth without destroying my gums. For 20 years I go in and they say, oh, you've got 5mm pockets. And I said, yeah, okay. Oh, it looks like I have the gums. I said, fine, we'll leave it like that. It's because I used to brush my teeth like this. Like that, they bleed, so they're clean, okay? Sonicare, the idea of Sonicare is gentle, I mean, you have to keep telling myself, just let it float across there, massage those gums, take more CoQ10, float across there, get that thing. And then here's a little secret. Dental hygienists don't want you knowing this little secret. So I really, you ought to all do this. Strange to say this in a heart lecture, but I have dental hygienists in my practice, and they bring me the scalers, the really professional ones, and I scale my teeth almost every night. And I am amazed. You go have your teeth cleaned once or twice a year, maybe twice a year, maybe every 3 years, whatever. Okay, I'm amazed how much stuff you pull off your teeth every 3 days, and we go 2 or 3 years. That's where the bacteria is hiding. All that stuff, get all that stuff out of there. That's what you're going there for, is get all that stuff, because all that stuff is irritating the gum lines there, the dentate line. Get all that stuff, and you can do that. You got to do it, carefully, but you can get those little scalers and get those teeth as clean as possible. You can't do it any other way. You can't do it flossing. You know you want me to do flossing. You can't do it. But Sonicare, and you get the scaler, it's really going to help you. But gum, remember, that's where a lot of bacteria is coming from. And avoid chlorine. I'm really big on this. It's oxidative. Get the chlorine out of your shower water. Obviously, you don't drink chlorine water. Get chlorine out of everything. Chlorine's an oxidant.
What about fluorine in the toothpaste?
I don't want to hear that. That's a different subject. Okay, so here's what you've been waiting for. I don't know if this is going to work, but this is the one you've been waiting for. Okay? Again, I don't know if the sound's going to work on this. But this is Matthias Rapp. And this is his theory of cardiovascular disease. And again, he's showing you kind of the same view that was going on before, which is that you've got, with lack of vitamin C, you've got all this deterioration of vascular deterioration, endothelial deterioration, and you've got a simulation of basically what is scurvy. So basically, what he's saying is, stop.
In America, the medical breakthrough I've led revealed that cardiovascular disease is an early form of the sailor's disease, scurvy. Vitamin C is the key molecule that keeps our arteries healthy and stable. Our body cannot produce a single molecule of vitamin C. When the sailors of earlier centuries tried to circumnavigate the globe and did not get fresh fruit for months, their arteries broke apart. Hundreds of thousands of sailors died from blood loss. The prevention and the cure for the sailor's disease scurvy is an optimum supply of vitamin C. Vitamin C helps to heal the weak and fragile artery walls. Today everyone gets some vitamin C and open scurvy is rare. But almost everyone suffers from vitamin deficiency. Over the years, millions of cracks and crevices develop in our arteries. Cholesterol and other repair factors in the blood enter these cracks and are laid down inside the artery walls. The deposits are nothing else than nature's plaster cast for a vitamin-deficient, weak blood vessel wall. Just as in the sailor's disease scurvy, so does vitamin C also repair the blood vessel wall in cardiovascular disease. The deposits are gradually dissolved and the fat molecules burned in the liver. The artery wall heals.
And this has been improved. So it's based on this concept of vitamin C, sorbic acid, proline, lysine, but big doses of proline, big doses of lysine. Lysine is antiviral, lysine for connective tissue, proline for connective tissue, carnitine, taurine, arginine, vitamin A, riboflavin, pyridoxine, vitamin E, a little bit of folic acid, vitamin K, and magnesium. So it's a little bit more than just the vitamin C. This stuff, it's been the big discovery for me in the last couple of months. Because I like powders. Because you can get big doses. It's not like taking 20 pills. Because people aren't doing it. This is way, tablespoon at night, you can take this. Now, what has this done? Well, now this is anecdotal, so I don't know. But I can tell you that my blood pressure is really good. My blood pressure was about, a couple months ago, I think it was about 115 over 75, which is real good. It's really healthy. Since I started taking this, my blood pressure went down to 105 over 65. My blood pressure is the same as my 25-year-old daughter. The same. So when we talk about anti-aging medicine and age regression, my lipids are better than they were when I was 22. My blood pressure is better than it was probably ever. So absent the fact that maybe I've got tremendous aortic stenosis that I don't know about, there is such a thing as age regression. And so is it this? I don't know. But when we look at lipoprotein A, the main way of treating lipoprotein A is niacin. A lot of my patients don't want to tolerate niacin. This is the other way of doing it. This may actually be the more effective way. I think the combination is probably even more effective than dynamite. So there's still the concept of the omega-3s and what omega-3s do. And I found this in my reading. I thought this is amazing. Because I know omega-3s are great, but look at this. Based on everything I told you tonight, what are omega-3s doing? They reduce endothelial expression of this vascular adhesion molecule, E-selectin, intracellular adhesion molecule, interleukin-6, IL-8, tumor necrosis factor, or bacterial endotoxin. So omega-3s just keep rising to the top in terms of their magic. And then niacin, again, look at this. Here's rises of HDL, LDL. Drugs don't give you that. Niacin does. So here's a sourcing. This is the one that I use. This one here is only available to docs. So probably what you're going to be able to find is this stuff called heart technology. And I'm going to warn you, this is great stuff. This is really great stuff. And it took me a while to find it. The thing I'm going to warn you about is the people who sell this are out to lunch. So you can get it, but don't try to get it tomorrow. And I think these guys are surfers, and I think they're kind of like, yeah, man, hey, dude, yeah, we'll get it to you. And then we call them and say, oh, yeah, I guess guess we were going to send that out to you, weren't we? So you're going to have to, these guys are really out to lunch. But their product is good, and this is the dynamite stuff, and it gets my highest recommendation.
Can you please flip the slide before and show what you're using?
Which,
The initial one, and you show the new using. It's from the same company.
yeah, the one that I'm using is this one here, okay, which is this here. That's the one that I use, because that has more in it. The one that you're going to get, which is Tower Technology, Heart Technology, is similar, but it doesn't have as much as this has in it. This is loaded with more stuff. I think it's got more arginine and a lot more vitamins and nutrients in it, but it's similar in terms of the main thing, which is vitamin C, ascorbic acid, proline and lysine. And again, I think proline and lysine, Raph talks about this, I think proline and lysine is antiviral, anti-cancer, as well as vascular friendly. You get a triple whammy with this stuff. This stuff's pretty dynamite stuff. Gets my highest recommendation. So we come down to the end. And I promise you this will be a long one, but we're getting down to the very end. These are the things here. Again, remember I told you? Bad, good, good. And so some final thoughts. It's Dean Ornish that said the greatest risk factor, and I haven't talked to you a lot about risk factors, the greatest risk factor is disconnectedness. So even though I've spent the whole night talking about all this stuff that's really important, in the end, it's disconnectedness that may be the greatest. That's loss of affection, loss of love. That's where you die of a broken heart. So it's not just this. That's why this still remains a rich and complex subject. The best way to reduce stress levels, maybe, that's what David Zava said. And even my son now has turned back to the Beatles, which I'm really happy about. And I just keep going over and over again, will you still love me? Will you still care when I'm 64? Because remember when we first heard that, we were all 25, and now we're real close, like Mick Jagger, to 64, okay? You never thought it was going to happen. It is amazing. It does happen to everybody. So these are some suggested readings here. And if you end up, this is what you want to watch for. I tried to find the original on this. One of the first things that I remember when I was a kid, the program, I don't know how many of you remember Medic. Anybody remember Medic with Richard Boone? That was the first medical program that I ever remember really watching when I was a kid. It came out in about 1956. It lasted for about 3 years. It was a great program. Actually, it had real doctors in it. And he had this little thing at the beginning which said, the eye of an eagle, the lion's heart in the hand of a lady. He said it a little differently, but that's what you want. If, God forbid, you do end up having surgery, this is what you're looking for. You're looking for the best. And so, we'll wrap it up because we have taken a long time here, but I tried to make this rapidly moving and really elucidate what's going on here. And of course, yes, I would like you to buy my book because I think you really get a lot out of it. And it was a lot of work, and there's a lot of good information in it. And that's it. Really
Okay, guys, I know we've been, it's been a long evening, but boy, I'll tell you, this is one of the best talks we ever had, and we're very grateful to you, Phil. And we'll all buy your book, I'm sure. But I also want to give you a chance, anybody who has to leave, don't be embarrassed to leave, but those who want to stay and ask a few questions, Phil's willing to stay here for a while, so you have Bernd.
On monokinase, Daiwa Pharmaceutical has the only monokinase that also prevents fibrosis and also treats it. They're the only ones that have a patent on it. And that's the one I use, and I recommend that highly. It's from Daiwa Pharmaceutical. They're out of Japan. I just had a meeting with them, and I was impressed with their science. It's totally prevention and treatment both.
See, again, and that may be true, Bert. For me, I use allergy research. And I use it because I've used it enough. I think this is one thing, you can't be switching brands around. You got to know exactly what the fibrinolytic units are. And so that's the one that I use. The question to me, really, the real ultimate question, is whether lumbrokinase is better than nattokinase. That's the question. So it's an open question.
Yeah.
Because there aren't any good studies on it.
They're both good.
You keep hitting on vitamin K, and yes, people are talking that to thin blood, the one thing you don't take is vitamin K. Now, I understand there's vitamin K 1, 2, and 3, and I know.
It's really complex. I don't have the final answer on this. I do know that vitamin K is the major thing that's controlling calcium flow between vessels, valves, and the bone. The question is, how does that interface with coumadin? It's not good with coumadin, but how does it work with nattokinase, and how does it work with the heparin? You know, what's the right dose? I still haven't worked it out, because this is where I recognize and I admit, I get better all the time, but I'm still not the best hematologist. But I don't think none of them are. I think the hematologists aren't any good either, so I'm gaining on it.
Yes, a couple of questions. What do you think about lecithin in terms of aiding vitamin C in the release of cholesterol deposits from the clogged arteries?
You know, that's kind of an old thing, and I don't know the exact thing. I use lecithin mainly because it increases choline. So lecithin, I use mainly to improve my brain function and libido. So I use lecithin and DME. In terms of what you're saying, it may do that, but I don't think it's a good answer.
Do you think that, as far as homocysteine is concerned, is there an animal model in which feeding of homocysteine actually increases the frequency of coronary events?
Yeah.
Would you consider it a marker rather than a causer?
Personally, I don't like animal models. So you're asking the wrong guy. I don't like animal models. I think if you're going to use an animal model, the only one that would work would be orangutans. And you're not going to do that. So I have a problem with rat models and mouse models and rabbit models and all that, because they metabolize all this stuff differently. So it might be good, but I don't like animal. I've never liked animal models.
Would it be possible to bring it to your book list slide? I didn't catch all the books that you had written on the slide there.
Yeah.
Would it be possible to...
I might be able to approach that to my website in the next couple of days.
Well, now we're going to have the video on, video available for the whole talk. And as a matter of fact, how many people would like to get a video for this talk? Maybe we should have Jim make some extra ones. Let's see, we got 1, 2, 3, 4, 5, 6. There's about 10 right there, Jim. So, okay. So it'll be available next month, right?
Yeah, it'll be available next month. Because they have to have it beforehand. They can just get the number off the website.
Right. Go to our website. You find Jim's number and you can get a copy.
Can you cut the slides into the video so we can actually have it be clear?
They'll be pretty clear. Yeah.
Yeah, I don't know. This is what I've been trying to work out. I don't know the answer.
Yeah, they have been coming out really well. I don't know how it's possible, but it works. It's come out really well.
Otherwise, Dave knows how to do that.
Yeah. Okay. Good.
So why do you want to prevent healing molecules?
Adhesion molecules?
Fibrin is a healing molecule.
Yes. Right.
ApoA is a healing molecule, and you want to prevent them.
Yeah, because they thicken the blood, and I think that they are. The question is, what are they healing? I told you this is an open question. I'm not a cut and dry guy. This is all. I like open-ended stuff. I like bringing out stuff where I do not have the answer. You don't have the answer. Okay? I think this is all open for discussion. I think that's where science advances, when you start questioning the most bedrock, fundamental assumptions. You say, well, wait a minute. It's like the cholesterol theory. Well, what about this? So it's a good question. My personal take is on it, I want to cut down fibrinogen, because generally fibrinogen is almost associated with bad things. Okay? When fibrinogen levels get about 500 or 600, I'm worried about cancer. And I'm not worried about impending strokes and heart attacks.
Cholesterol is also associated with bad things.
Right, okay. So what you do is we want to try to prevent the bad things that increases the cholesterol to begin with. And there's genetics.
Some of your nutrients are at very high levels, like enzyme 10, 200 to 600, vitamins.
Those are therapeutic levels.
How do you come up with those levels?
Those are therapeutic levels. That's for people who have heart disease. That's not necessarily what you're going to be taking every day as a maintenance dose. Maintenance dose depends on age. younger age, maybe 50 milligrams, maybe 100 milligrams, maybe 200 milligrams. My granddaughter, who's 2 years old, she takes 100 milligrams a day, okay? Because to her it's candy. So, what can I say? She's running around. But those are therapeutic doses, and those are doses that are not arbitrary capricious. Those are doses where I've done blood levels on those, and I've seen the blood level you want to get is 2 to 5. And I don't think anything less than 2.5, I don't think is therapeutic. I think if you want to treat heart disease, you're going for 5. You're not fooling around. So all this stuff where they show CoQ10 doesn't do anything, they're using like 2, 2.5 as their cutoff. You want 5. So this is not arbitrary. I've done this based on what I get blood level. Because I have guys who are taking 900 milligrams. Yeah, so I know what their blood levels are.
You mentioned about several drugs that can mainstream cardiologists use. But the congestive heart failure is not accompanied by thrombosis and coagulation. They always prescribe beta blockers and diuretics. You didn't say anything about those.
Right. What I do in anti-aging medicine is functional medicine, and it's integrative. I mean, I hate all these terms. Functional, integrative, or like energy medicine, but that sounds too far out. But integrative means that, I don't say that all of it, I throw it away. I mean, I've been at this for, 33 years, so it's not everything I did 10 years ago was like cast away. I use it all, okay? But I'll tell you, I've never liked beta blockers. I think they are terrible. Because beta blockers will almost always lead to depression. This is what they do. They depress the nervous system. So I don't like beta blockers. I've never liked the rationale behind them. I don't like the use of them. I think they're terrible drugs. Diuretics, on the other hand, they're useful. I use them. I do use them because they do work.
You had a diagram up about a pattern A and a pattern B.
Yeah.
And I was confused by what I think I heard, which was that in some cases you can have a certain high level of LDL and it's okay, and in some cases it's not. Could you please explain that?
Well, what the pattern A and pattern B means is that for a given level of LDL, they could be small LDL particles, pattern B, or it could be large LDL particles. Same level. So your LDL may be 130. But if you have an LDL that is 130 and you have a pattern B, that's worse than an LDL of 130 that's a pattern A. Okay? So all they're doing, you're just showing how big the majority of these particle sizes are.
But then the question is, I guess, how does one know if it's pattern A or pattern B, and how does one know the size of the LDL particles?
By the VAP testing. That VAP testing tells you that. That's what you get from it. And Berkeley Heart Lab will give you that too.
Phil, you never told us why Merck didn't put CoQ10 with their product. I have an idea, but why don't you tell us?
Well, one can impugn all sorts of sinister things, and I'd like to actually go through that because it's kind of like the Synthroid story. The Synthroid story was a determined effort to bamboozle and whitewash the medical community into thinking an armored thyroid was only for quacks. With this stuff here, I don't know. I think you can impugn a lot of different things. Maybe they decided it wasn't worth it, they didn't want it. I don't know, but it wasn't honest. It wasn't honest.
What's your thoughts on the role of probiotics in this?
It's not my big specialty. I mean, I like probiotics, but I think it gets into an area that, all gut health is really important. It controls vitamin K, controls a lot of assimilation, how well you're assimilating. But it's such a complex thing. What I do, a lot of the endocrinology and a lot of the medicine I do, again, partly because of, my background, which is biochemistry, and partly because of emergency medicine, I like my patients to see, I do something, you see the result in a couple of weeks or a month. To me, when I do GI stuff, and when I see other people doing GI stuff, it's great stuff and I love it, but you're not going to come back to me in a week saying, man, I feel better. I've never felt this good. Okay? You get better, and it's doing all the good stuff, but it doesn't have the dramatic stuff. It's important. It's not my forte, but it is important.
Sort of 3 questions about cost effectiveness and usefulness. On vitamin E, you have mixed tocopherols, but you don't mention tocotrienols.
Yeah, I'm big on tocotrienols.
Okay, so we should add that in.
Yeah, I'm really big on tocotrienols. This was not designed to be the definitive. Just say, these are really important ones, there are other ones in there. Tocotrienols, I'm really big on tocotrienols.
Acetyl-L-carnitine, is it worth more money than regular carnitine?
Personally, and we have this discussion, you know, because everybody's got this idea. Personally, my feeling, you get carnitine levels up, because people are not taking enough. Now, Robert Crayon and I were really big on this, and I've had these long discussions with Robert. He's really big on carnitine. You get it up to 6 grams, and I'll tell you, if you have never taken carnitine in high dose, and you start tomorrow, and you take 3 grams tomorrow, right off the bat, you are going to be high. You're going to be buzzy. And if you're high and buzzy, what does it tell me? It got in your brain. So if it got in your brain, then that whole thing about, well, you know, carnitine doesn't cross the blood-brain barrier, I think it's all dose-related. So I think that there are some advantages. There may be the polarity in the way it acetyl-L-carnitine and some stuff that it gets into, and I know Steve might say something about it. But personally, I think if carnitine levels high enough, I don't use acetyl-L-carnitine.
Okay, so you think that was the most cost-effective. But
Yeah.
one was serapeptase versus navigase. If you're taking big handfuls of both.
I'm not big on serapeptase. Maybe okay. I'm just not big on. I'm really big on navigase.
One more last question.
No. Let me just add.
Yeah, okay, go ahead.
Phil. Okay. In terms of acetyl-L-carnitine, I've known some people that it makes a difference, where they have to use the acetyl form, but most people don't need it.
See, so Steve actually agrees with me.
You mentioned bias. Why do you prefer bias over trias?
Estrone is a very, very harmful estrogen. And I'm trying to keep estrone levels down because David Zava will talk to you about this, that estrone is a ketone, it's an oxidized form of estrogen. It leads into the 2 and the 16, I think the 4 and the 16 form, which potentially are proliferative, lead to cancer. Estrone's a bad one. You don't need estrone. You're making plenty of it. I give you estriol and estradiol. You're going to make plenty of estrone. I'm trying to keep those levels down. I think estradiol is fine, and estriol is okay. Estradiol is fine, but estrone is not good, so I don't give it.
Okay, how about another hand for Dutch? Just bear with me for 60 seconds more here. If there are any doctors or practitioners in the audience that I don't, that I haven't met, I'd like to meet you because we'd like to include you in the group, more intensely and get you participating, and so please talk to me or talk to one of our other board members, but I would particularly like you to talk to me. Secondly, I would like to remind you to pick up the Linus Pauling Institute newsletter, which is over there, and I strongly recommend that you all subscribe to that. In fact, it's free. You get that newsletter, you call the number, and they'll send it to you every quarter for free. And also, I'd recommend the Life Extension magazine. And now let me turn it over to Dave Yost for one final question.
I have a question. When Dr. Whitaker spoke 2 months ago, he also touched on the issue of the Merck patent about CoQ10. And somebody in the audience said, a quote something like, "Old man Merck said in the 40s that we have to manufacture diseases to treat." Who said that? Is anybody here who said that? Okay, I tried to track down that quote and I couldn't find it.
Okay, thank you all for coming, and we'll do it again next month.